Hello, everybody. Welcome back to the Incubator Podcast. We are live at the CHNC, and we are joined by the amazing team from the CHNC, Anthony Piazza, Eugenia Pallotto, and Beverly Brozanski. Guys, welcome back to the show. Well, Have you been on the show, Jean?
Yes, last year.
Yes. So that's why I was correct by saying welcome back to everybody.
And welcome to you as well.
No, I mean, this is so much fun. How are you guys doing so far?
Good, excited.
We're doing great. We don't have as much work to do as Anthony.
That's true. That is true. Anthony is like the manager of the rock band, running around, making sure that everything is...
Indeed is the manager of the rock band.
So we are talking about QI, and we're talking about the QI priorities of the CHNC. What we were saying with Daphna on our introduction of the coverage is that the symposium feels very much like a working meeting. People get a lot of work done, do a lot of brainstorming, do a lot of planning. But can you take us a little bit into the inner workings of how does that happen? How do we set priorities for specific projects, and in this case, QI? I'm going to let whoever wants to take this one first.
Well, specifically with QI priorities, we have a steering committee that has representatives from multiple sites and they're QI experts at their sites. We also want to engage the membership. So when we're deciding on a quality improvement project, we want to hear from the group. What's important to them? What's applicable to all their sites? And then we take that back to the steering committee to really, process and make sure it works with the priorities. But it's really a team sport, like any quality improvement.
And I'll add to that, and we try to use the data that's available in the database, because then if we can have that data as the outcome, we're already collecting it. And then we only have to work extra to collect the process measures.
Yeah, that makes sense. Trying to leverage what's already like almost like a low hanging fruit, saying, hey, if we have all this data, how can we work with the data to have to answer some meaningful questions?
I'll also add to try to get a cohort of patients as broad as possible, rather than being niched into a single diagnosis, but including a lot of diagnoses that affect a lot of patients.
And one of the things we learned is that we are so varied. Like our outcomes, no matter what we look at, are varied across institutions. So we do have a lot of things we can learn from one another.
And I'm assuming that various institutions have different interests and different things that they would like to pursue. So you have to work with these competing interests between institutions who would want to pursue a specific question, a specific topic, and try to make sure that you're not stretching everybody too thin either.
That's exactly right. And also different resources that a hospital has. Some don't have as much resources for quality improvement than others. And so we learn from each other what is important to have to make the project successful.
And we have a phenomenal steering committee with experts in QI who are good at making something out of nothing. So, kind of when you're doing this, then you do that all at the same time. So they're really good at helping our teams work with the resources that they have.
Yeah, I think that's crucial. And so what can you tell us a little bit about the place that QI is taking in the research landscape and the collaborative efforts of the Children's Hospital, especially the ones that are part of the CHNC? Because I think we've seen QI just take off in the past 10 years. And it seems to become the go-to modality of trying to study and get answers relatively quickly that we can act on, rather than more of a prolonged process that sometimes can come with a formal double-blind RCT international stuff that really means you're in for a long haul of data collection and analysis.
Well, and that's something we're really working on right now. So how does the organization help centers do all of that?
Right.
So we have our large national collaborative multi-center that's a 2 or 3 year cycle to really get that done. So our next phase now is really leveraging the CHNC platform so teams can have their quality improvement data back to them in the right time series way so they can work on the projects they need to. Not everybody needs to work on all the same things. So using that database to support the teams is kind of really our next phase, and also opening up to supporting smaller quality collaboratives.
So is there any particular niche that you're excited about that's slowly coming to life?
We've had requests or discussions with a lot of different groups. I think BPD in particular has talked about some quality improvement initiatives. Our discharge and transfer focus group has also kind of proposed a project. So we're really open to what, the audience needs and participants needs. But those are the two that have bubbled up.
I'll also add maybe the social determinants of health, especially in like Project Home, which is our breast milk at discharge project. Getting into those analytics, we're learning there's so much variation that we probably need to do different interventions for different populations. So
can you tell us a little bit about what Project Home is?
Well, Project Home is home on breast milk every time for every patient. And so what we've learned when we've disaggregated our data in St. Louis, for example, is that white moms with insurance have the highest breastfeeding rate at discharge. And white moms without insurance are very close to black moms with insurance. And black moms without insurance really lag way down. So really, it depends on your population. You need to figure out what you can do for those populations that need it most, right? So that's really kind of what we're excited about in the next phase.
Absolutely.
So many things that we're excited about, though, right? We can't possibly do it all.
So for Project Home, we did our due diligence with literature research and trying to figure out what are the right processes to make the outcome of going home on breast milk. But the literature may not reflect our patient populations, not only through race and ethnicity, but also from our patient population being primarily referral based, a lot of surgical patients. So it's a little bit different than what the literature may have pointed us to as the processes that need to happen. So we may come back and find new things that are just as important as what's in the literature right now.
And I guess the only thing I would add to that is it is a both and. Even if we're doing all the things that we need to do to get moms to start breastfeeding early on, beyond those few weeks when moms go back to work, they may not have the supports to pump at work or the social supports to keep it going. So I think there's so many factors that play a role into this particular project where our process measures are so focused on the early time point, and the outcome may not come till several months later for some of our patients.
I think what's interesting about all this is that through a QI initiative, you are getting sort of a glimpse into what the reality of life looks like for these families outside the NICU. Because in the NICU, we have everything controlled. Every variable is controlled for whether it is our vents or our medications. But once, like you said, Beverly, once parents go home, they're subjected to so many forces and so many stressors that suddenly the reality changed dramatically. And through this QI initiative, you're getting a glimpse as to what are the effects of poverty on the families who are caring for medically complex children, and so on and so forth. And I think that's kind of an unintended benefit of QI where you never thought this would be what you,
Exactly.
Yeah.
I think the other thing I would like to add too is there's so much shared learning and benchmarking that really you could never get until you get 35 centers together talking about these things.
Right.
So it's something like kangaroo care that you would think is totally implemented in every NICU is really a challenge, but learning from others and knowing that they're doing it safely helps empower other sites to make those changes.
And what can you tell about specifically that where quality improvement initiative sometimes make you look at how different units are practicing different ways, and like the quality of the intervention is different everywhere you look? And how do we look at variability, and how do we look at precision medicine, and how do all these things come together to create a unified project that could potentially benefit every single center that will read the output of that study or of that collaborative's work?
You know, that's the beauty, I think, of QI. We can develop our clinical practice recommendations, but then each center has to implement it based on their resources, their population, their culture.
Right.
Right. So that's what's the beauty of QI versus research, right? Because it's not as rigid. You just kind of move it along based on your own population.
Yeah, I love that.
Then I'm going to step out and let Brianna step in. So I can help out.
I'm going to wrap this one up and then we can bring Brianna in if that's okay. Yeah, that's okay.
Yeah.
All right. So thank you all three. And I'm very excited about the different QI projects that are ongoing. The presentation that you shared with us is quite interesting. And again, a lot of very interesting measures that you're focusing on. So congratulations.
Thank you.